Clinical Practice Guidelines and Quality of Care for Older Patients with Multiple Comorbid Diseases by Cynthia et al. Objective: to evaluate the applicability of clinical practice guidelines to the care of older individuals with several comorbid diseases. Measurements: the National Health Interview Survey and a nationally representative sample of Medicare beneficiaries to identify the most prevalent chronic diseases in this population. The National Guideline Clearinghouse for locating evidence-based clinical practice guidelines for each chronic disease. Of the 15 most common chronic diseases, we selected hypertension, chronic heart failure, stable angina, arterial fibrillation, hypercholesterolemia, diabetes mellitus, osteoarthritis, chronic obstructive pulmonary disease, and osteoporosis, which are usually managed in primary care. Choosing clinical practice guidelines promulgated by national and international medical organizations for each. Two investigators independently assessed whether each clinical practice guideline addressed older patients with multiple comorbid diseases, goals of treatment, interactions between recommendations, burden to patients and caregivers, patient preference, life expectancy, and quality of life. Differences were resolved by consensus for a hypothetical 79-year-old woman with chronic obstructive pulmonary disease, type 2 diabetes, osteoporosis, hypertension, and osteoarthritis. We aggregated the recommendations from the relevant clinical practice guidelines. Introduction. The aging of the population and the increasing prevalence of chronic diseases poses a challenge to the development and application of clinical practice guidelines. In 1999, 48% of Medicare beneficiaries aged 65 years or older had at least 3 chronic medical conditions, and 21% had 5 or more. Healthcare costs for individuals with at least 3 chronic conditions accounted for 89% of Medicare's annual budget. Comorbidity is associated with poor quality of life, physical disability, high healthcare use, multiple medications, and increased risk for adverse drug events and mortality. Optimizing care for this population is a high priority. Clinical practice guidelines are based on clinical evidence and expert consensus to help decision-making about treating specific diseases. Clinical practice guidelines help to define standards of care and focus efforts to improve quality. Most clinical practice guidelines address single diseases in accordance with modern medicine's focus on disease and pathophysiology. However, physicians who care for older adults with multiple diseases must strike a balance between following clinical practice guidelines and adjusting recommendations for individual patients' circumstances. Difficulties escalate with the number of diseases the patient has. The limitations of current single disease clinical practice guidelines may be highlighted by the growth of pay-per-performance initiatives which reward practitioners for providing specific elements of care. Because the specific elements of care are based on single disease clinical practice guidelines, pay-per-performance may create incentives for ignoring the complexity of multiple comorbid chronic diseases and dissuade clinicians from caring for individuals with multiple comorbid diseases. Quality of care standards based on these clinical practice guidelines may also lead to unfair and inaccurate judgment of physician care for this population. We examine how clinical practice guidelines address comorbidity in older patients and explore what happens when multiple single disease clinical practice guidelines are applied to a hypothetical 79-year-old woman with 5 common chronic diseases. We discuss the results in the context of incentives that are created by pay-per-performance and related healthcare initiatives. Methods. Clinical practice guidelines included in the review. To identify the diseases most prevalent in older individuals in the United States, we reviewed data from the National Health Interview Survey and a nationally representative sample of Medicare beneficiaries, 5% of the standard analytic file. We defined a chronic disease as being present when a patient had 2 outpatient claims or 1 inpatient claim for the disease during 1999. From the 15 most common chronic conditions, we selected 9 that are usually managed in primary care: hypertension, chronic heart failure, stable angina, arterial fibrillation, hypercholesterolemia, diabetes mellitus, osteoarthritis, chronic obstructive pulmonary disease, and osteoporosis. We excluded depression and dementia to focus on patients who would be most likely to adhere to recommendations and understand health information. Among the 5% sample in 2001, half of the beneficiaries had at least 2 of the 9 chronic diseases, and 80% had at least 1 other condition. We identify the most recently released as of March 1st, 2005, evidence-based clinical practice guideline promulgated for each chronic disease by national and international medical organizations using the National Guideline Clearinghouse. Data abstraction. Our review was based on standards for developing and rating the quality of clinical practice guidelines. Indications of high quality included describing the target population, grading the quality of evidence supporting recommendations, discussing therapeutic goals, addressing quality of life, and incorporating patient preferences. We examine the concepts of competing risk and burdens of treatment for patients and caregivers because these issues are central in the care of older adults with multiple diseases. Two investigators, CMB and JD, independently abstracted data from each clinical practice guideline about applicability to individuals aged 65 years or older with multiple comorbid diseases and the quality of evidence for this population. Indications for treatment, feasibility of treatment, or modified goals for treating the index disease in the setting of comorbid diseases, and duration of therapy necessary to achieve benefits in the context of life expectancy. We reviewed clinical practice guidelines for discussion of patient-centered aspects of medical decision-making, including effects on quality of life defined as explicit discussion of quality of life, physical function, or symptoms such as pain, dyspnea, differentiating between short and long-term effects, goals of treatment, for example, cure, arrest progression of disease, preventing complications, or managing symptoms, incorporation of patient preferences or shared decision-making, and burden of following recommendations on patients and their unpaid caregivers, defined as explicit discussion of burden or of the aggregate weight or intensity of therapy to either patients or caregivers. Of 117 abstraction decisions, investigators disagreed on 22. All were resolved by consensus after discussion between reviewers. Most disagreements involve statements that appeared ambiguous to the reviewers. Some explanation is provided in the tables, and additional details are available on request from the authors. Hypothetical patient. We examined the feasibility of combining the treatment recommendations from relevant clinical practice guidelines for a hypothetical 79-year-old woman with osteoporosis, osteoarthritis, type 2 diabetes mellitus, hypertension, and chronic obstructive pulmonary disease, all of moderate severity. We abstracted the recommendations, medications, self-monitoring tests, environmental change, diet, exercise, involvement of specialists and other clinicians, and frequency of follow-up from the relevant clinical practice guidelines and assembled a comprehensive treatment plan using explicit instructions from clinical practice guidelines whenever possible. We attempted to develop a treatment plan as simple and inexpensive as possible. When several options existed, we selected generic medications with the least frequent daily dosing and least potential for adverse effects. To reduce complexity of treatment, when possible, we chose medications recommended for more than one condition and combined self-care activities whenever possible. We identified conflicts that emerged when relevant clinical practice guidelines were applied. For example, potential adverse effects on other diseases when treating the target disease, interactions between recommended medications, and interactions between food and medications. We tabulated the number of medications and medication doses per day. We quantified the complexity of the medication regimen by summing the number of different dosage schedules weighted for dosing frequency. For example, once per day equals 1, 3 times per day equals 3. A regimen with 7 different medications consisting of 4 drugs taken once per day and 3 drugs taken twice per day generates a complexity score of 3, 1 plus 2. A regimen with 1 drug taken once per day, nightly, 2 drugs taken twice per day, and 1 drug taken 3 times per day has a complexity score of 6, 1 plus 2 plus 3. We estimated the cost of the regimen and calculated anticipated out-of-pocket cost with coverage by Medicare Part D. Now, before we continue, I wanted to take a moment to go over how the medication complexity score was calculated. So suppose you had 7 drugs, an Alive multivitamin, an Advil, an Airborne immune support, omega-3s, Tylenol, aspirin, and lisinopril. Now suppose the first 4 you were taking once per day. So Aleve multivitamin once per day, Advil once per day, Airborne once per day, and then omega-3 multivitamin once per day. Now assume you're taking the Tylenol 2 times per day, aspirin 2 times per day, and lisinopril 2 times per day. Then your medication complexity score is going to be 1, 2, and then 1 plus 2 equals 3. Results. Applicability of clinical practice guidelines to older adults with comorbid illness. Although 7 of the 9 clinical practice guidelines discussed older adults or comorbid diseases, only 4 clinical practice guidelines, diabetes, osteoarthritis, arterial fibrillation, and angina, addressed older individuals with multiple comorbid diseases, as shown in Table 1 and 2. The clinical practice guidelines addressing osteoarthritis, osteoporosis, and chronic obstructive pulmonary disease did not discuss the quality of evidence underlying recommendations for older patients. Only clinical practice guidelines addressing diabetes and arterial fibrillation discuss the quality of evidence for older persons with several chronic diseases, as shown in Table 1 and 2. The Diabetes Clinical Practice Guideline notes the absence of evidence favoring tight glycemic control for older patients and suggests that looser control may be appropriate for older adults or individuals with a limited life expectancy. 7 clinical practice guidelines made recommendation for treating the target disease in conjunction with a single other chronic disease, as shown in Table 1 and 2. Discussing possible adverse effects of following the recommendations, the Osteoarthritis Clinical Practice Guideline recommended gastroprotective agents in older patients taking certain anti-inflammatory drugs and mentioned that clinical trials excluded patients at high risk of bleeding. Only the clinical practice guidelines for diabetes, chronic heart failure, angina, and hypercholesterolemia gave general guidance about treatment in the presence of several chronic diseases, as shown in Table 1 and 2. The clinical practice guidelines addressing chronic heart failure and hypercholesterolemia discuss treatment in the setting of other cardiac diseases, but not of non-cardiac diseases. Only the diabetes clinical practice guidelines discuss the relationship between life expectancy and the time needed to treat to achieve benefit, as shown in Table 1. The angina clinical practice guideline discussed life expectancy in the context of interventions that could lead to invasive procedures, but did not address duration of treatment required to achieve benefit. This table shows the first 5 of the 9 chronic conditions the author reviewed, with the results of the abstraction for each disease-specific clinical practice guideline present in the column corresponding to the disease. For example, the clinical practice guideline for diabetes mellitus addressed treatment for older and multimorbid patients. Additionally, these guidelines assess the quality of evidence for older and multimorbid patients and found that the quality of evidence was poor, requiring extrapolation for nutrition recommendations. The guidelines provided specific recommendations for patients with hypercholesterolemia, hypertension, congestive heart failure, chronic kidney disease, cardiovascular disease, peripheral vascular disease, and benign prostatic hypertrophy. Specific recommendations for patients with several comorbid conditions were included in these guidelines. And finally, time needed to treat to benefit from treatment in the context of life expectancy was also discussed. So take a moment, pause the video, and review the results for the remaining guidelines. This table is a continuation of the previous table with the remaining 4 clinical practice guidelines. Again, take a moment, pause the video, and review the results. Inclusion of patient-centered domains in clinical practice guidelines. None of the clinical practice guidelines discuss the burden of comprehensive treatment on patients or caregivers. 3. Hypertension, angina, and hypercholesterolemia acknowledge patients' financial burden. The Diabetes Clinical Practice Guideline mentioned the discomfort and inconvenience of self-monitoring blood glucose. The Arterial Fibrillation Clinical Practice Guideline noted the quality of life can be affected by drug interactions and the need for frequent blood tests in patients taking warfarin. None discussed balancing short and long-term goals, such as when short-term quality of life is better without a treatment that provides long-term benefit. The Osteoporosis and Hypercholesterolemia Clinical Practice Guidelines did not discuss quality of life. 7 of the clinical practice guidelines discuss patients' preference about medical care, but this was often without guidance for incorporating preferences. Only the chronic heart failure clinical practice guideline explicitly discussed preference for end-of-life treatment. Applying clinical practice guidelines to a hypothetical patient. Applying the relevant clinical practice guidelines to the hypothetical 79-year-old patient, we generated a possible treatment schedule that would result if all the recommendations in the clinical practice guidelines were followed, as shown in Table 3 and box. The patient would take 12 separate medications with a medication complexity score of 14. The regimen requires 19 doses per day, taken at 5 times during a typical day, assuming that albuterol as needed is taken twice daily, plus weekly alendronate. Some non-pharmacological recommendations apply to more than one disease. 14 non-pharmacological activities were recommended for this patient if all nutritional recommendations are pooled into one. The clinical practice guideline also recommended one-time educational and rehabilitative interventions and monitoring of the patient's chronic diseases from daily to biennial intervals, depending on the type of monitoring. It theoretically would be possible to compress all monitoring into 2 to 4 primary care visits and 1 ophthalmologic visit per year. However, patients often have several clinicians, although in some regions and managed care settings, most care may be provided by a primary care team. All elements of the treatment plan cannot easily be addressed in a 15-minute office visit. This table here shows the recommended tasks to be completed by patients and clinician based on clinical practice guidelines for a hypothetical 79-year-old woman with hypertension, diabetes mellitus, osteoarthritis, osteoporosis, and COPD. Go ahead and pause the video to take a moment to review those tasks. This table here shows the 12 different medications, their dosage and frequency, along with the 14 non-pharmacological activities the patient will be required to perform by time of day. So let's go over this together. The first medication that we see is ipratropium. And they'd be required to take that at 7 a.m., 1 p.m., 7 p.m., and 11 p.m. The next medication would be calcium, taken 3 times a day at 8 a.m., 1 p.m., 7 p.m. Vitamin D, taken 3 times a day at 8 a.m., 1 p.m., and 7 p.m. Hydrochlorothiazide, that's a mouthful, taken at 8 a.m. Lisinopril, again taken at 8 a.m. Glyburide, 8 a.m. Aspirin, taken at 8 a.m. Metformin, taken at 8 a.m. and 7 p.m. Naproxen, taken at 8 a.m. and 7 p.m. Omeprazole, taken at 8 a.m. Levastatin, taken at 7 p.m. and albuterol, taken as needed. So what I want you to do is go and review all the medications that you're required to take daily and go ahead and make a table like this. Interactions that could result from concurrent adherence to all 5 clinical practice guidelines are shown in Table 4, include between a medication and a disease other than the target disease, between medications for different diseases, and between food and medications. Recommendations may also contradict one another. If the hypothetical osteoporotic diabetic patient has peripheral neuropathy, the osteoporosis clinical practice guideline recommends that she perform weight-bearing exercise, while the diabetes clinical practice guideline cautions that some patients with advanced peripheral neuropathy should avoid weight-bearing exercise. The patient's medication would cost her $406.45 per month, or $4,877 annually, assuming no prescription drug coverage. Beginning in 2006, she would be able to purchase drug insurance under Medicare's new Part D. If her income is above 150% of the federal poverty level, as it was for more than 60% of the Medicare beneficiaries, she would pay an out-of-pocket premium of $420, a $250 deductible, $500 of the next $2,000, and 100% of the next $3,000. In her case, $2,627. Thus, assuming current prices with drug insurance, she would pay $3,797 per year plus $373 for any future drug expense for that year. The non-pharmacological interventions recommended involve additional expenses to patients, informal caregivers, Medicare, and other insurers. So before continuing, I wanted to take a moment to go over how the cost of medications per this patient were calculated. So for the first $420, this is going to be her premium. And what this means is that before she even pays for any of the medication that she needs, she's going to pay $420 for that year. And she's going to pay $420 whether she uses the insurance or she doesn't use the insurance. Then, the first time she uses insurance, she's going to have a $250 deductible. She's going to be required to pay only $500 for the first $2,000 worth of medications that she purchases. So if she only purchases up to $2,000 worth of medications in that year, she'll actually only pay $420 plus $250 plus $500. However, in this case, we see that she purchased $4,877 worth of medications. So for the next $3,000, she's going to be required to pay 100% of that, which is going to come up to $2,627. So plus $2,627. So when we add this all together, she would pay $3,797. Now we can do some quick math and say, well, $3,797 divided by $4,877 equals 23%. Equals 77%. And so insurance covered 23% of the cost of her medication. This table here shows the potential treatment interactions for a hypothetical 79-year-old woman with 5 chronic diseases. So in the first column, we have our type of disease. In our second column, we have the medication specific to that type of disease and which are likely to interact. So hydrothiazide and lisinopril are likely to interact. And these two medications are more than likely going to be taken by a person who has hypertension. And certainly in this example, they are. In the following column, we have medications and other diseases. So what this shows is that the medication that the person is taking for hypertension, the diuretics are going to increase the serum glucose level, which is going to have an effect on the diabetes. In the following column, medications for different diseases, we see that the hydrochlorothiazide may decrease effectiveness of the glyburide, which is being used to treat the diabetes, and there are no interactions between medication and food that are associated with the medications used for hypertension. So go ahead, take a moment and pause the video and review the results of this table. Comments. This review provides evidence that clinical practice guidelines do not provide an appropriate evidence-based foundation for assessing quality of care in older adults with several chronic diseases. Although clinical practice guidelines provide detailed guidance for managing single diseases, they fail to address the needs of older patients with complex comorbid illness. While some recommended interventions for specific pairs of disease, clinical practice guidelines rarely address treatment for patients with 3 or more chronic disease, a group that includes half of the population older than 65 years. Payment to physicians in the pay-per-performance program is frequently based in part on their meeting quality of care standards created for a single disease is according to a calculated rate of adherence to the standards within an eligible population. While these standards are not explicitly taken directly from clinical practice guidelines, they are often derived from clinical practice guideline recommendations. The Medicare Payment Advisory Commission recommended that Medicare adopt pay-per-performance for physician reimbursement. The Commission suggests a trial period during which physician reimbursements would be based on adoption of information technology measures with feedback to individual physicians on performance on condition-specific claims-based processes measures, followed by a date certain when condition-specific claim-based process measures would be included in physician pay-per-performance. Medicare initiatives and demonstrations incorporating pay-per-performance are becoming increasingly common. The clinical practice guidelines are not designed for use in quality assessment, so transforming clinical practice guidelines into performance standards and applying these standards to the care of older patients with complex comorbidity is problematic. These guidelines are recommendations based on varying levels of evidence and assume application of clinical judgment and patient preferences, both of which would be difficult to measure in a pay-per-performance scheme. Quality indicators must balance scientific evidence against what is practical and feasible to measure rather than what is a higher priority, i.e. assessing yearly screening for retinopathy rather than aggressive blood pressure control in diabetics. Many indicators have upper age limits, for example 75 years, thereby excluding a large percentage of Medicare beneficiaries and removing incentives to focus on these patients. Most indicators do not address the burden of comorbid diseases. While it would be feasible to omit sick patients from computations for reporting purposes, this would remove the pay-per-performance incentive for improving care for this patient. Assessing physicians on the basis of care they provide for individual diseases obscures the complexity of treating real and particularly older patients with several chronic diseases. Patients in whom single disease standards cannot or should not be attained, but who are eligible to be in the population base for a given standard may become medical hot potatoes if their physician receives lower pay-per-performance scores as a result. Current pay-per-performance initiatives can create financial incentives for physicians to focus on certain diseases in younger or healthier Medicare patients. These initiatives perpetuate this single disease approach to care and fail to reward physicians for addressing the complex issues that confront patients with several chronic diseases. Standards that define quality of patient care regardless of a patient's health status and preferences by placing emphasis on attaining high rates of adherence to clinical practice guidelines rather than more difficult tasks of weighing burden, risk, and benefit of complex therapies in shared decision-making could ultimately undermine quality of care. If quality assessment focuses on younger or healthier patients, there's additional risk that these problems will go unnoticed. Quality of care standards are needed for older individuals with several chronic diseases. Critical but currently unreimbursed processes of high quality care for this population include care coordination, patient and caregiver education, empowerment for self-management, and shared decision-making that incorporates individual preferences and circumstances. These processes should be incorporated into quality of care standards and pay-per-performance initiatives. Standards for developing clinical practice guidelines note the importance of identifying the target population and incorporating quality of life and patient preferences to improve adherence of both physicians and patients. The clinical practice guidelines we examined do not give explicit guidance on how to do this. Providing optimal care as defined by several clinical practice guidelines for patients with comorbid conditions quickly becomes difficult in terms of cost, medication complexity, and the magnitude of the task. Practicing physicians adjust clinical practice guideline recommendations for individual patients judging risk and reacting to patient preferences, but best practices for making these adjustments remain undefined. Coexisting diseases may increase or decrease the benefit of an intervention for a target disease. Future clinical practice guidelines that address how to incorporate quality of life and the risk, benefits, and burden of recommended treatments for older adults with comorbidity would be more useful than currently existing clinical practice guidelines, but training physicians to use clinical practice guidelines while incorporating these principles is also critical. The guidelines could address common comorbidities, but more obscure comorbidities would be difficult to address. Clinical practice guidelines addressing several combinations of comorbid diseases would be more unwieldy and be based on scant evidence. To provide evidence for optimal care for older patients with several chronic diseases, future trials should include older patients with representative comorbidities and should investigate shared decision-making among those patients, their caregivers, and physicians. A few noteworthy efforts address these issues. A recent clinical practice guideline for older adults with diabetes discusses the quality of evidence and gives a practical advice about geriatric syndrome and prioritizing care for older persons with several chronic diseases. The Assessing Care of Vulnerable Elders project proposes quality of care markers for chronic diseases and geriatric syndrome in frail older adults and recognizes that goals of care and preferences affect definitions of quality. Patient-reported measures of quality of care address access, continuity, coordination, communication, and empowerment for patient and family involvement. Some pay-for-performance standards include provision of educational resources and measures of patient experience. Our analysis has several limitations. First, we did not attempt to examine all clinical practice guidelines. Instead, we selected clinical practice guidelines generated by prominent professional organizations and published in widely read journals, which are likely to have a high impact on clinical practice. There may be less well-known clinical practice guidelines that provide better guidance for the care of older adults with multiple chronic diseases. Second, in designing the treatment regimen for our hypothetical patient, we used our clinical judgment when the clinical practice guidelines were not explicit in their recommendations, a task clinicians face daily. While other clinicians might arrive at slightly different regimens, we believe they would have similar complexity. For the present, widely used clinical practice guidelines offer little guidance to clinicians caring for older patients with several chronic diseases. The use of clinical practice guidelines as the basis for pay-per-performance initiatives that focus on specific treatments for single diseases may be particularly unsuited to the care of older individuals with multiple chronic diseases. Quality improvement and pay-per-performance initiatives within the Medicare system should be designed to improve the quality of care for older patients with multiple chronic diseases. A critical first step is research to define measures of the quality of care needed by this population, including care coordination, education, empowerment for self-management, and shared decision-making based on the individual circumstances of older patients. So if you're with me still, I want to thank you for tuning in, and to say thank you, I wrote the following riddle. I'd love to see your answer in the comments below.